Just starting our live stream. We'll give folks a minute or two as a lot of people are joining. I think we'll start relatively promptly. I'm sure a few more people are joining. In about 1 minute, we'll start at 9:32. All right. Thanks everyone for joining. I will be joined today with, as you know, several of our ESS colleagues on, and Commissioner Barton Reeves will be joining us. I did want to start us off with just announcing some, I'd say, some exciting news. Guy Woolston, our Medicaid director, who many of you have now met, they just had their first baby, and he and his partner are out on parental leave, and very excited for them. And hopefully they're getting to spend a lot of time learning how to enjoy some sleep deprivation and figuring out those first couple weeks. But they're back and all healthy in New Haven at this time. So just wanted to let everybody know. So you won't be seeing him at this meeting or the next one, but we'll be excited to have him back sometime in the fall. So the agenda for today. And again, based on a lot of your feedback, we've attempted to kind of curate the agenda moving forward and adjust some of the topics we'll be covering. And so we'll spend, as you can see, a significant amount of time at the end on a listening session. We'll be first kind of going through an update on the data requests. I'm sure some of you had noted there's a fair amount of data that's come through. We'll talk about that next. We'll talk about the goals for today. We'll do a check-in to make sure that we're on the same page as to where we are and where we're going. And then we're planning on providing some information about some existing DSS initiatives related to health-related social needs, social determinants of health, and then informing on broader strategies, including L1115s, to address those needs. And so again, thanks. This is very much in response. We're trying to be responsive to a lot of the feedback we've received and appreciate from all of you as part of this process. So the next slide, we'll talk about the meeting schedule, so kind of where we've come from and where we're going. Again, this is an we've adjusted our timeline and extended that really by 6 months, as you may recall in our discussion from the last meeting in terms of the work for this group, and of thinking about how we might launch a new program. And we discussed kind of the scope of the primary care redesign in prior work a bit more in detail at the last meeting. Today, again, we're talking about really trying to focus on listening session about how do we address individual and community needs, and providing a little bit of context and background of what DSS is doing and some data that our colleagues at CHNCT have been collecting. And then we're looking forward at the next meeting. We know we sent you a lot of information that you have not had time to fully digest, is to have a meeting in August where we have a curated discussion about some of that data. It would be very difficult to do all of it, but also we've gotten some feedback of the interest of having a additional supplementary meeting that's optional to go more in depth for those who are interested, which we're also happy to record and live stream. We know that scheduling over the summer may be challenging, but we want to at least offer that opportunity based on the feedback we've received so far that there's interest in that. So I want to take a moment to, and then I should also point out, sorry, that in September, we're going to be looking to have a in-person or at least hybrid meeting for those who are available somewhere mid-state area. We're finalizing details where we all can get together, spend some time discussing, hopefully maybe some key programmatic design features and have a robust conversation. I should also add, in addition to the curated in August, in addition to a curated discussion on some of that, the data that we sent out, we also be interested in discussing specific primary care program examples, which you all had mentioned interest in discussing. So I want to take a pause, wanted to solicit your feedback to see how this course sounds in terms of today and moving forward. And we'll talk again, and we'll talk a little bit more about the goals. So I wanted to pause for a moment. Feel free to jump in, any committee members on input you have.
Sounds like a good plan, Brad.
Agree. Thanks, Brad.
And again, this won't be your final. We sent out a poll ahead of time. We'll also solicit feedback after this meeting from all of you. And just to kind of one thing about scheduling, we're going to be, ideally, we want to continue to get feedback from all of you about our process and topics and where we're headed, understanding we won't have pure consensus, but we want to at least make sure we're soliciting that information from you. So if there'll be more time further, if folks feel like later on, if you want to provide commentary later after this meeting and you say, hey, actually, this wasn't exactly what we had envisioned or what I had envisioned, that would be helpful. Mark.
Thanks, Brad. And thanks also for such strong efforts to be responsive, both with respect to data and creating space for these deeper conversations, including community today. The one, since we have a long road ahead of us in terms of meetings, the one process request I would make is if it's possible to distribute the slide decks or other material a week in advance of the meetings. Sometimes we like to have a chance to both review and also discuss and be prepared. And there was, even in the deck alone, it was quite a bit to wade through. So if that was possible, that would be much appreciated.
Understood. We'll see what we can do. We'll take that back. Thanks, Mark. At this time, seeing no other, we can kind of move forward. Again, welcome feedback on this, even towards the end. So if other folks want to chime in later after this meeting, feel free to. Update on the data request. So we know we send out a lot of information. You requested a lot of additional data and information. We wanted to be responsive to that. A lot of thanks to my colleagues, Dr. McGraw and his CHN CT team, as well as Olivia and the FCG team for helping both pull it and then compile it. And so just running through some of this. So just as a frame of reference, we know we just sent this information. It's a lot. We know you probably haven't had time to fully digest it. We are, again, planning on taking time today to talk about that green area with prevalence of health-related social needs as part of this conversation. The rest of the data, we are hoping to, again, have a supplementary meeting to discuss for those who are available and interested, as well as having a more curated conversation on some of this data as part of the August meeting. So I just wanted to tick through what we are able to provide. And so that includes unattributed member data, pediatric cost utilization, quality and outcomes, member experience metrics, measure of access by geographical area and practice setting, utilization and cost, and prevalence of chronic conditions. There was a few questions on measure of access by subpopulations and by member preferences, but we don't have any data that would be responsive to that. So we've been trying to be as responsive as possible. I'm sure there's more data that might be of interest, but this is our attempt to be as comprehensive as we could be in the time allocated. And sorry, I know our CHN team spent a lot of time compiling and pulling this together, and came in at close to this meeting, and that's really why we're wanting to spend more time later digesting, giving you opportunities to both digest it and discuss it. Let me just check. And I think, and see commissioners join, so welcome, Commissioner. Good to see you here this morning. And I think we can move on to our next slide, kind of going over the goals for today's meeting. So really, one is to try to be responsive to the committee's request to have more conversations about addressing health-related social needs and social determinants of health, which we'll define shortly, inform the committee about DSS's starting point and pathways for broader initiatives, and gather and share ideas to inform the primary care payment reform initiative or the development of broader HRSN or health-related social needs initiatives. And just as a reminder, the goal of the work of this committee is to develop, with your guidance, a primary care program that improves the biopsychosocial well-being and health of our members, especially for those most historically disadvantaged, and in a way that reduces inequities and racial disparities. However, I also wanted to just say, as we discussed last time, that we know that primary care is, while a foundational component to our healthcare system that can help, identify and maybe address some of the health-related social needs, it is not the whole solution. And so part of, just acknowledging that, but also saying that we think it's important, and we also want to have this broader conversation that's about primary care, but also more encompassing. And so just helping frame the conversation for today, and also our acknowledgement of where this work for this committee, as we've kind of structured it with guidance from others, is heading. So now just to jump into some terminology on social determinants of health and health-related social needs. So these two terms are used relatively interchangeably often, though we wanted to define them for you because we think it's helpful. Some of you are experts in this area, but we think useful to provide some context. So the definitions we're using for social determinants of health here is the conditions in the environment where people are born, live, work, play, worship, and age that affect a wide range of health, functioning, quality of life outcomes and risks. And then health-related social needs in individuals' unmet adverse social conditions that contribute to poor health. These needs including food insecurity, housing instability, unemployment, and/or lack of reliable transportation, and drive health disparities across demographic groups. So it's important. CMS has been using health-related social needs in a lot of their recent 1115 or in their 1115 waiver approvals, as well as in other documents. But you'll see again some of these terms used at times interchangeably. I personally like to think about it as social determinants of health being the broader term under which health-related social needs falls. And so I often personally like to use it in that framework, though there's some debate about how best to use both of them. But for our purposes today, that's how we're using it. And you will note them used relatively interchangeably. So on the next one, we're going to return to some slides that you've seen a little bit before. And this is just to say that we are at DSS interested in pursuing strategies outside of this work to address health-related social needs. But the purpose within the primary care payment reform initiative is really to think about primary care, building a primary care program that provides flexibility and incentives to identify members' health-related social needs, refer members to providers who can help address those needs, and assist members in arranging for and obtaining that. So again, framing this, the work of this committee fitting in this bucket, but us today talking about things that are more encompassing. And we also, again, will be getting to those broader strategies under consideration, including 1115 momentarily. But next, we wanted to actually highlight on the next slide some of the DSS initiatives underway that currently exist or are being launched to try to address some of these. And we're not going to spend a lot of time on them today. On the next slide, you'll see a little bit more information as well as resources and links to that. But I just wanted to highlight the ones that we have. And there's actually more than this, but we wanted to give you a curated list. And then we are going to spend a little bit more time on the ASO CHW assessment plan that I'll pass to Larry in a moment. But we can go back to the prior one, and I'll just say, so CHESS is our supportive housing program that's in coordination with both Medicaid and non-Medicaid services. Some of you may be very familiar with this. INC, or Integrated Care for Kids, is a CMMI-sponsored program, New Haven-based, with the lead organization being Clifford Beard, helping to provide more comprehensive wraparound services for children. We've recently expanded coverage for violence prevention professional services. This is to reimburse violence prevention professionals to help mitigate the effects of community violence. There's support grants, support grant, that's a 1003 demonstration program that's in coordination with DCF and DMIS to assess provider capacity for substance use disorder services in Connecticut. There's also a assisted living community options program that's for specific individuals with the goal of helping them live at home or return home to community. And then SUD 1115 demonstration waiver that's looking to improve care across the continuum for individuals with substance use disorder. And then the Family Bridges program, which is the universal home visiting and community health worker program, which there's is a ARPA funded pilot in the Bridgeport area that's in collaboration with 5 other state agencies to provide universal nursing visits for newborns and their families, as well as incorporating CHWs to help identify health-related social needs and other social determinants of health and linking individuals to resources as part of it. So I know that's very high level. There's more resources here. We just wanted to let you know about some of the things that are currently being done in DSS or in partnership with DSS. And I'm going to pass it over to Dr. McGrath to talk about the work that CHN has been doing and is currently underway with some of their CHW work. So,
Brad, I'm sorry to interrupt you, Dr. Workforce. But before you do that, because we've just presented a lot in a short period of time, we just want to take a little bit of a break and see if anyone has any questions or reactions before we turn it over.
Sounds good.
Okay. And if not, it's quiet.
I guess
Okay.
the thing that I want to comment, thank you, Commissioner, is that there are pieces all over the state, not really covering the state. Maybe some of the projects are more across, maybe cities or whatever, but that's it. We tend to do this little piecemeal and not roll out across the state. Maybe the SUD waiver is, but I know Inc. is actually just 2 zip codes in New Haven. So,
Yeah.
That becomes, to lift it up across is really where the rubber hits the road.
Yeah. So Dr. First, I think you're right. Sometimes that's a strategic decision we make with respect to the demonstration waiver, right? Just depending on what kind of success we think we'll have with CMS. Sometimes they feel that if we do it statewide, it's a very heavy lift and we don't have as much success in getting the approval to even start a demonstration if we do that. But in some instances, I think we do think about whether or not it should be statewide. And that's why I think you'll be, I just had a little preview of the presentation that's coming. So we'll actually get a chance to see where the critical social determinants of health are across the state. And that I think will help us with our planning going forward. But so I think it's actually a very good point that we can just add to the decision-making as we move forward. Good morning, Ellen.
Good morning. I want to have a politely disagree with Alice. I think we do need to pilot things. There's a lot of things that just roll out. They sound like good ideas, but in the end, they're not effective. They maybe work in one place. I mean, Alice has an amazing facility in New Haven that may not be easy to spread everywhere. So I think actually going slowly makes a lot of sense. I know there's a lot of urgency in the problem. I get that, but doing something that wastes time, energy, money, and honestly, you only get so many chances at these things. That if you fail, sometimes it's really hard to get policymakers to come back to it.
Right.
Ellen, I agree. I think, I'm sorry, I don't mean to think, I agree with you. And I didn't mean that we shouldn't do small pilots to move. It's just moving when it does succeed, moving it into a larger distribution is where I see some problems. But thank you.
Moving it carefully.
Okay. So Polly, I'll take your question and I'll turn it back to Dr. Richards. So I want to make sure that I just inserted myself. I don't want to do that.
No,
Go ahead, Polly.
I appreciate that. Mine is maybe more of a statement. So I appreciated,
Sure.
This kind of oversight or kind of overview of where these new initiatives are underway. I think I would also, make sure we also understand what existing structures like WIC and SNAP and VAO, there are a lot of resources that are already in existence that are really important when we're talking about social drivers of health and health related social needs. So to me, that was a little bit of a gap in some of the materials here, because we know those individuals that are in the Medicaid program are also potentially eligible. And I don't know that we always make the connections and ensure that individuals that are eligible for services are even kind of getting the full suite of services that they may be able to take advantage of.
Appreciate it, Polly. I'll just say, I think definitely something that we are definitely aware of and interested in trying to assist individuals with and make sure they are getting access to all the services they may be that could benefit them. It's definitely a work in progress. Mark. Maybe
Go ahead,
we'll
Mark. Yes, we'll let Mark. Go ahead, Mark.
Thanks. So I have with an eye toward the care delivery discussions ultimately leading toward a discussion of payment reform. I'm interested. One of the things that I wonder about is how one can create accountability structures and reward structures that reward collective efforts across the broad range of actors that are necessary to achieve certain outcomes. And so you have a number of maybe isolated initiatives is not fair to say, but you have a portfolio of initiatives here. And the question is, what kinds of incentives are at play that where there's really a shared contribution to be made to certain outcomes? As a practical matter, for the Integrated for Care Kids for Care program, is that a total cost of care accountable program? And if so, are patients attributed to PCMH Plus also attributed to Inc? And if so, how do you reconcile the relative contributions to a shared savings dollar, given you've got two accountable entities involved?
Great question.
Erica, sorry,
Yeah.
go ahead. Erica, did you want to
Yeah,
start?
I was gonna say Erica
Yeah.
can answer that one.
Yeah, and then we'll turn it back over to Brad.
There are certain folks in eligible for Inc program that are not going to be eligible for other programs. And in terms of the PCMH Plus and Inc providers, none of those providers are part of the Inc program currently. And we would need to take a deeper look into how we would coordinate that. We do not see, and one of the things that we've considered with all of our care coordination programs across the state that any of our members could participate in, we do not view the care coordination services that are part of Inc to be the exact same care coordination services with the PCMH Plus. So there's a level of accountability that would be needed to take into consideration in terms of what exactly is being. So in other words, there would be on the Inc side a responsibility to coordinate the care coordination services.
So I thank you, Eric. I'm certainly familiar with the innovative approach that's being used for Inc and what it's trying to demonstrate. I guess I'm wondering, just on a practical basis, can a youngster or family members be attributed for accountability purposes to both the FQHC that might be providing primary care and to the Inc program?
Yes. And what would need to happen is the responsibility for ensuring that there's no duplicative efforts of care coordination would be on the ICC, the intensive care coordinator's role. That would be their role, being they'd have to take lead in coordinating care services.
And the savings that are generated, so if they're part of a population where savings are generated, how are the savings apportioned between Inc and the FQHC? And if you don't, if that's a hard question to answer now, I'm curious because of where this ultimately where this work is headed, how that works.
Well, it's a great question. One in which we probably would have to talk more about, Mark. We're not going to see that being an issue at this rollout at this time. And it may not be an issue in the near future, as well as we consider the changes. So right now, that is not, we do not have any scenario in which that is going to impact anything.
Thank
Well,
you.
and specifically, Mark, this is Joel Norwood from DSS. We're not, the Inc. performance measures don't look at savings right now. What they will do in the future, I don't know, but Inc. doesn't pay based on savings.
Thanks. So whether it's Inc. or the maternity bundle is an episode-based model, so it's less complicated, but where you're talking about programs where you have an eye toward total cost of care accountability. And as we look to primary care reform, which potentially could be about that, I just wanted to sort of raise that as a question. I know CMMI has been preoccupied about how coexisting models sort of play together, and you don't share a dollar twice and so forth.
Right. We know that much, and we've taken that into consideration, certainly.
Thank you so much.
Thanks, and I think this will lead nicely into our conversation towards the end and kind of as a nice primer for that. So thanks, Commissioner, for helping us take a pause and for kind of starting this conversation. I think this is now, I will pass it over to Larry to talk about specifically the CHW program. And again, we can continue this conversation as we approach the end. So anything that has come up for you or you guys are thinking, please take note, and we'll make sure there should be hopefully adequate time to discuss as we reach the end.
Thank you, Brad. Good morning, everyone. For those of you who don't know me, I'm Larry McGraw. I'm the Senior Vice President for Population Health and Chief Medical Officer at Community Health Network of Connecticut, Inc. We are the medical administrative services organization for the Husky program. And again, I thank you for the opportunity to highlight one of DSS's initiatives that we have been partnering with them for a decade now, our CHW program. So the program began in 2014 under our care management programs, really to supplement the clinical team, basically doing outreach in the community to members that the care management teams were having a difficult time reaching, so they could do house calls, et cetera. In early 2020, we moved them over to our community engagement team because the work that they were doing aligned more closely with some of the other work that was happening in our community engagement area. And then in July of 2022, we actually, at DSS's request and with collaboration, expanded the program fairly dramatically. So we now have 36 community health workers in 2 teams. One remains a dozen in the care team, which still supports the care management programs. So they specifically target members who had an emergency room visit or an inpatient hospitalization discharge, and that the care management teams cannot connect with. So they are an additional resource to try and get the member to the care management team, or to connect the member to a primary care provider, so that they are engaged in care and don't continue to use the ED for primary care. The second team, which is really the expansion team, is a new outreach program, and there are 23 or 24 community health workers on that team. It has been an expansion since July. You don't flip a switch and have 24 new CHWs ready to go. So we've been onboarding. They go through a 6-month training and they do become certified. They are hired regionally in the geographies in which they serve, so that they are familiar with the community resources. They're matched to that community, and can provide culturally based education to members that they interact with. So those are the 2 teams and who they serve. How are members screened in order for referral? So again, the ICM team, the care management team, does have a dedicated group of individuals, and then the outreach team serves other groups, including member engagement services representatives. Whenever a member calls our member call center, and they actually manage just about a little under 20,000 phone calls from members a month. Every member is asked if they can be asked some screening questions on health-related social needs, and if a need is identified, they are referred to a CHW. Every new member is asked to complete a health risk questionnaire, which is an online form, and if their needs identified, they would have outreach. And then there's also reporting from claims and from the existing OB pay for performance encounter forms, in which providers who are seeing pregnant Husky members can notify us of health-related social needs. And anybody can refer a member using the Husky Health member 800 number. So just a couple more points on this slide. So you can see that we are getting information from a lot of sources, and we didn't have a good way to measure outcomes. So I challenged our IT and population health teams on how we could integrate all the data that we were receiving so that we could aggregate that and look at what types of needs we were seeing were most common, where were these, statewide, where were these needs showing up, and then was there a way we could track an outcome once a need was identified and a member was referred. So if we flip to the next slide, we created a social determinants of need dashboard that aggregates all that data. We did identify, so there are 8 nationally recognized domains of health-related social needs, and then there are 23 subdomains. So when we look at our dashboard, we created a 1-year look back because we know that these needs are dynamic, not static, and change over time. Someone who was experiencing homelessness 2 years ago may not still be, so we do limit it to a 1-year look back. And using that 1-year look back through all of the SDOH sources that I've mentioned, we identified a total of about 57,000 SDOH needs that had been identified, and that represented about 42,000 members. About 10,000 of those had more than one health-related social need. And we can break that out by the practice setting, with the other being unattributed members, where we found the information about the SDOH needs. So claims is the most common there, and I'm sorry it got cut off, but that's over 30,000. But again, to put things in perspective, that's 30,000 claims out of the millions and millions of claims that are submitted annually. So it is less than 0.1% of claims. So that tells me that these are still being way underreported. And we've been working with the primary care practices, particularly in the PCMH Plus and FQHC, to improve their capture of social determinants of needs using the ICD-10 codes on claims that are submitted for this very purpose so that we can track them. I think we can flip to the next slide. And our top 3 are listed there. Again, more on member demographics. So by age, by race, by gender, by which Husky program we're seeing them in, with A and D being predominant, not a surprise because those are our largest program, whether they're in care management or not. And then in the bottom right corner, when I talked about outcomes before, again, we did not have a way to track outcomes. So if somebody had an identified social need and one of our community health workers referred them to a community-based organization, we did not really have a way of tracking an outcome unless we called that organization, which is very resource intensive and very task oriented. So we partnered with Unite Us, and I want to thank Dr. Schaefer and the Connecticut Hospital Association for the introduction. They are an electronic platform that mimics an EMR in the community so that you can track referrals and referral outcomes. So we get data back from Unitas on the referrals that we make to them. That is visible across the entire care continuum. So visible to us, visible to care teams at the hospital if the patient shows up at a hospital, and visible to the other community-based organizations that may all be participating in the care of that patient. So somebody who's being seen for food insecurity and housing insecurity, that data is shared across those different organizations. We started that as a pilot in Bridgeport. It was so successful that after 6 months, we went statewide with it. So if we move to the next slide, you can see the number of members that were referred through the Unitas platform, what they were referred for, and we get, how many cases are closed, how many are still in process or pending. We have all of that data. We did include in the slide deck, in the appendix, this type of breakdown for each of the 8 main domains, not the subdomains, but the main domains of social determinants of health. And that is there for you to peruse. Commissioner Barton-Reeves did comment on the fact that we are looking at this data geographically. We did not include the maps in the slide deck, but I am happy to share it live on the screen if the members of the committee would like that. I see the commissioner shaking her head. So Olivia, if you could stop share, I will go ahead and share my screen, and hopefully it hasn't logged me out, the app. And so basically, what you can see here is the map of Connecticut. This is not adjusted for population, so it's not normalized per 1,000 members. But the point is that there are fairly dark areas and fairly, lightly populated areas of the state, so that we can see that this is a statewide problem. I am able to filter here by any of the 8 subdomains. So I could select, for example, housing, and then we could see how the map changes to show where housing insecurity is existing in the state. I will stop share and pause and ask if there are any questions on what I just presented. Ellen.
Thanks. I couldn't see it really well, but it looks like it's a New Haven problem, which is probably something we should talk about at some point. So you have, that data was on 42,000 people that were identified as having social determinants, and you clearly recognize there's a lot more, among 1 million people in the Medicaid program. That's a very small number. So I think we should look at all of the data that comes out of that with that lens. Was that mainly or only people from Team 1? So these are ED, they came through ED high utilizers, is that right?
No, there is, this is just data that's collected from any source that we get it on. So we are saying that, it's really seriously underreported, but yet what we see here already outstrips our ability to service all those members. So even with 36 community health workers, we can't service 42,000 members. So there are a lot of members with needs who are not being addressed currently because we do not have the resources at this point to go after every one of the 42,000 members with an identified need. So I think it ties into, what can providers help with, what other means do we have of addressing this, because even an established and fairly large program just is not meeting the needs of the community or the population.
And another that I noticed earlier, that most of the members identified never got any case management and did not respond. I think that's a serious, I think we need to know why that is. And maybe it needs to come from a different source. And that also might solve your problem of not having enough resources to reach everybody. that may, different people need to be approached. Somebody needs to hear about it from their church. Somebody else needs to hear about it from the school. And I think a broader network. However, I started a mild hyperventilation. I need to know more about UNITA US and who's seeing what. Do they see EMRs? The people
No,
at food
I
pantry.
said it, I'm sorry, I said it was EMR like. So basically,
Okay.
it's just a platform for following referrals out into the community. So a member, they have an opt-in, opt-out process. So a member who is being referred. So we do. I saw a comment about 211. So a member, could be referred directly through 211 or can be referred through the Unitas platform with consent. There is no health information attached to this. This is strictly to address the social determinant of need. Mark, you may have additional information on that you may want to add. I don't use the platform personally, so I have not seen what the referral looks like, but it really gives visibility for SDOH referrals across the community-based organizations. And I see Polly also shaking her head. She may have referred patients through that platform.
I think Ben Wade's up.
Hi, thank you. My name is Ben Wade. I'm new to the group. So just a little bit of background about me. First off, thanks so much for letting me join. I'm the Chief Strategy Officer at Stanford Health. I've been with Stanford Health for about, coming up on 6 years. And in addition to my role in strategy, I also have responsibility for community relations and a lot of our health equity work. Prior to joining Stanford, I was at Montefiore, which is a large progressive integrated academic health system in the Bronx. And while I was there, I led all of Montefiore's district work and built community-based networks to help address some of the very things that you're talking about. This program, really, thank you so much for sharing the information. I just had two questions. The first was, actually, you pulled the slide up, that far left pie chart, where you're looking at referrals by practice setting. I was wondering how that compares to overall attribution in the Medicaid program. I would imagine that there's a lot more unattributed members in the general population than in the referred population. Is that true?
That is correct. The unattributed population represents about 22% of the total population.
Okay. So that's smaller than I thought. So that's interesting. Thank you. And then the second question I had was actually something that you started to talk about, which is just the sheer demand for these services versus the resources that you have on your team. And I wondered if there are any, perhaps something you can share offline, any performance statistics that you could share about, time to response or, success at closing the loop. We have a fairly large Medicaid population at the Stanford Health Medical Group, and I would be very interested to tell my colleagues about this program.
The program was expanded in July of 2022 and has been in a ramp-up stage. It takes 6 months to onboard and get a community health worker certified. So we are in the first year of the program and still collecting data on how long does it take an organization to complete a referral, which I think is what you are driving at, Ben. More granular data like such as that.
Yeah, if you have, we don't need to go into it on the call, but I was wondering if you had any, just information about once you receive a referral, how long does it take for you to respond to a client? Then once you respond, how long does it take to get them connected to care? What percentage of people, how many follow-ups does it take? I mean, anything at all that you could share, I would be interested to learn more.
That is the type of data that we're just starting to aggregate now because of the rapid ramp up of the program and the needs to hire the individuals to fill the spots, et cetera.
Absolutely. Thank you so much.
There was a question in the chat about who is responsible for increasing the percent of case management. The case managers have a risk stratification tool that they use already to identify high cost, high need members who are unattributed. I think, Ellen, you had made a comment about a high number without case management. And I think that's one of, that's just reflective of the fact that case management is trying to reach these members and have not been successful, and are then using the CHWs to do that member outreach to try and increase their connection both to primary care and to our case management programs. Karen, I believe you are next.
Hi, all. I'm so sorry, I was having some technical difficulties. And if you've answered this question already, please move on. But I was curious. So for the members who have an identified need that can't be met, is any information provided back to them? And how are those screenings being conducted? Is this something that's an online tool? Is this something that's being conducted in person by CHWs, by phone? Thanks.
Yep, they do outreach by phone first, and if they are unsuccessful, they will try and connect with the person in the community. So literally, they walk and knock on doors that identified addresses. That's not 100% successful because people have moved. We know the challenges. We know the challenges with people not having to renew eligibility for the last couple of years. So that's all being worked through. And then once they do connect with the member, they give them the opportunity to have the assessment done in person, face-to-face, in a public space, in their home, or over the telephone.
And so what information do they receive if they have an identified need that you can't get back to them on or can't support?
So I didn't intend to say that there are needs that we cannot meet. We cannot handle the volume that we identify through claims, if that makes sense. So we have a stratification tool where we're identifying the highest need or risk members for direct outreach. We can't go after every one of the 42,000 members who we have information about health-related social needs that we can identify in a claim or something like that.
Okay, so those people are not being screened at all,
Correct, yeah.
Okay.
We don't have the capacity to screen everybody.
And are you tracking? Oh, sorry, go ahead.
It doesn't mean that it's not being addressed, because it could be addressed through a source outside of CHN. We might identify it on a claim, but as Polly indicated in the chat, Yale New Haven Health System is using Unitas, so the primary care provider may have already referred. So, that the visibility into Unitas gives us a little more options. So before outreach is made, they would look into the system and say, okay, so we have an identified social need here. Is this being addressed by somebody else?
And just to add, I think part of this broader conversation about primary care payment reform is, where should some of these services and referrals and identification be coming from? And then obviously we have obviously the work that Dr. McGraw's team and CHN is doing is a little bit more of that centralized approach. And where one of the questions is, where does primary care broadly fit into both identifying and addressing or helping coordinate some of these services? And so I want to frame it a little bit in that conversation, take a step back and say, yes, we are doing something at the moment. Part of the question is, does this make sense to have it as a centralized, being centralized address, or are we looking, which we've kind of tried to do with PCMH Plus and obviously with integrated care for kids, is trying to push out to those communities where those services are and those providers may be located. So this is an ongoing discussion. I think that we're part of this. Robin, sorry, none of your hands up.
Thank you. I just, as I just had a couple of questions, even in terms of how the connection, and maybe you have already mentioned it, but I guess as I think about this and as I'm looking at everything, just wondering also with the CHWs in terms of as we talk about, equity and looking through the lens of equity. I know you said that they come from the community in which they're actually serving in. But the question I wanted to know is that in this process, do they have access to the primary care providers to help kind of navigate and also advocate for, some of the services or maybe some difficulties? And then just wondering, even in this network, is it intentional to have, persons of color that are in the, primary care as well as, in the primary care practices and stuff for persons that, because I think it's also important that you can have a CHW that comes from the community and everything, but even in the connection to primary care doctors, do they look like them as well?
So we are actually looking at opportunities to better match members to primary care physicians. That's just in the formative stages. So right now, a community health worker is either trying to connect the member to our care management team, which is clinical and does have relationships with primary care offices to try and make that connection, or they are encouraging a member to select a primary care doctor in an area that is accessible to them using the provider directory, the Husky provider directory.
And are they part of the team, in terms of them coming together to kind of discuss some of the needs and some of the referrals that may be needed or linkages that may be needed for particular persons? The community.
Yes, they participate in all our care management rounds, and they also participate in the community connect teams that are geographically based and across multiple different organizations.
And Robin, are you?
I'm happy to connect you with the individual who manages our community engagement area if you would like to have an offline conversation with her. Tressa Spears Jackson.
Okay, thank you.
Yeah.
And maybe just to say, I think one of the pieces that we're talking about related to addressing some of these is that primary care providers may not have capacity or don't have capacity to integrate with some of these other resources and are not necessarily incentivized to do it, even to do more coordination. There is some, obviously, for some of our programs currently, but part of this conversation is how can we think about potentially doing that more? And so that is, one, we wanted to obviously show you this information about what's currently being done, but what can we do in the future and where can we go from here? And I think the next hand up is Alice.
Yeah, hi, thank you. First of all, I'm a great fan of CHN, and I think the work you guys are doing on the community health worker end is really important. Having done care coordination and addressing basic needs, in particular for families who are in distress, and this is our second CMS innovation project, working with families who have, high physical, mental, and social determinant or driver needs. I think that the way that we have to think about this work has to be from a public health aspect, that it isn't driven by primary care or even mental health, that we have been working now for a couple of years on INC, and our first groups of folks were community health organizers. We're going out into the community, we'll replicate the community and engage in conversations around needs and engage conversation around the community and what the environmental needs are in the communities, and have some power and impact to be able to make some of those changes within the community. The really high cost, highly difficult families need a lot more than just a call or a visit or a knock on the door. You have to be in relationship with them. You have to build trust You have to build accountability amongst your staff, and you need to follow the family or the individual's lead. If they say to you what they need is access to a battery to get their car going, you have to actually help them access a battery to get their car going, because they think, and it could be absolutely true, that they would be able to make their doctor appointments, so to be able to get the kids or their individuals where they need to go. And so where do you get the money to get a car battery? You don't like call AAA and say, give a donation. But Connecticut could perhaps work out a system where those kinds of car repairs or whatever, there is a network for that. But what we do in DCF funding and what we've supported in our integrated care for kids are flex funds to be able to purchase that $50 or $150. In our last CMS project, we averaged about $600 per family in flex funds that actually addressed it. And I'm just going to give you one example, and I'm sorry, I don't mean to talk too long, but I know really passionate about this, as Erica and folks on the call know. You know, a family asthma was the driving factor of kids going to the emergency department, right? And we had an experience where we had a primary care nurse located at the Yale New Haven primary care clinic. And every day she looked and saw who was in the hospital. One day she called, a lot of the kids were going in because of asthma. And, you know, she would call the family and make sure that they got, yes, we got our pump. We understand what we're doing. But it turned out actually that the drop-down list in Yale New Haven Epic was not the countable asthma pump, but rather just the pump that just worked. And it worked when it was full, and it worked when it wasn't full. And what she was able to do was to work with Epic to bring the countable, Medicaid pays for the countable asthma pump, and have that be the first thing that dropped down. But that was a very concrete problem that had to be addressed through multiple systems. And, you know, there's a tremendous amount of examples. You could give somebody a coupon for asthma, HepaVac, or a mattress cover, and they could maybe get themselves to the warehouse to pick that up. But if it's a single mom with little kids, who's going to help her put that mattress cover on, right? That's the kind of health and relationship needs to be built when you're working with high needs and, you know, families with multiple subdomain of needs. So it has to be public health. It has to be widespread. And I don't think it's a primary care problem. I think it's a community problem. Thank you.
Ellen, and then Angela, and then I think Stephanie has hand up, and then we're going to try to just move. We'll have more. This is part of it. This is honestly great because this is part of the conversation that we wanted to have today, and just want to make sure we had a little bit of framing on 1115s as well to help understand like some of the context for which this conversation is having. So Ellen, and then Angela, and then Stephanie.
I agree completely with Alice, and everything she said. She's right that people's problems don't fit neatly into the system we've developed, and centralizing it, I think, just it more. When she says it needs to be widespread, whenever you centralize something, there are protocols in place and things get lost and options are lost. It's a problem when you centralize things. I think that's a very bad idea. I'm thinking more along the lines of a web, and everybody's attached to it. And maybe there's, you know, one data analytics source, but in terms of services, there needs to be a lot of options. My other concern is putting it all under primary care or basically anything in the medical model. Our medical system in the United States and in Connecticut is not an efficient system. It, you know, as one advocate said to me, you know, if we give the money to health systems, only 10% of it's ever going to get down to, you know, to people. And community organizations know how to work, you know, on a shoestring. So I think that's in terms of getting people what they need. Also, in terms of trusted messengers, some people will trust their primary care doctor, but some people and rightly so in the communities we're trying to get to, have an understandable aversion to the medical community, and they have good reason to. If anybody wants to look at it, just read Medical Apartheid. It's a long book. It's hard to read. I had to put it down many times, and I was embarrassed as a former scientist, but there's good reason people don't, when they trust certain sources and they don't others. I think there are really serious concerns even about unintentional steering through the medical system. Somebody's on your board, so you send people there and you don't necessarily know someone else. And the communities work in a web. They don't have a central organizing system who goes into the community and tells everybody how they're going to do everything. I don't think so. I think the needs have to come through a web as well. And I also really want to push for upstream prevention. And once somebody's in a place where the medical system is much more downstream, we're a sick healthcare system. We're not a healthcare system, we're a sick care system. And all the things that Alice talked about were upstream, preventive, community-based, public health-based. And I think that's where we should be devoting our resources. And if we free up some from the medical system, we're going to have a lot more for all those great things. I share Alice's soapbox on this.
Angela again, and then Stephanie.
Yes, good morning. Just would like to lift up a couple of follow-up points and questions. Thank you, Alice, for what you shared, and Robin. How many service providers are using the Unite Us system across the state? And generally speaking, are healthcare providers hesitant to ask questions that they are unequipped to provide solutions for during their short, maybe 15 minutes of time with an individual as they are engaging in the health space? And then finally, we had the presentation from CHN, and just with the backlog of maybe up close to 42,000 folks, many needing case management, are we going to be intentional about using community health workers from community-based organizations to, build their capacity to reach more people in a shorter amount of time, so that we can make some types of inroads to get help to the people that are clearly in need, particularly system navigation and access to food could put a huge dent in a major cause of multiple health-related chronic problems like diabetes, obesity, and get help and attention to some of those areas. I know I've asked a lot, but if I'm not sure what the intent or the time frame is, but I think I only heard about one pilot in Bridgeport, and we definitely, with the passage of legislation this session, have the ability to do more if we're intentional.
Thanks so much. I'll just say the Unite Us, I don't think we wouldn't have the numbers on how many people are using it. We'd have to probably ask Unite Us that question, though. I imagine CHA and some other folks might have some information, but I think not sure. Probably pretty widely used by a number of providers, but don't have those numbers. Just as a primary care provider myself, and someone who's still seeing patients at times, there's not the correct resources often to address those needs. As someone who often asks people personally about access to services, it's challenging to, one, find time to help them, and also often feel limited in ability to do it as of now. And so I think that appreciate you elevating that as part of this conversation. I think what was already been brought up is it can take a lot, and it's important to have those trusted messengers as well as the right people. And I don't think as an MD, we're always the right people. We can help think about how it affects people's health, but we're not always the right people to actually do all of this work, obviously. And then agreed, in terms of the legislation, I think we broadly, and I'm definitely passing to Commissioner Barton Rees, are interested in thinking about how to expand CHW landscape, given the recent legislation that is part of what we will be interested in working with the broader community and thinking about what does a VSS CHW benefit look like, acknowledging there's not currently appropriated funds for it, but there's an opportunity to do a design phase. Commissioner, I don't know if you want to add anything else to that before I pass it to Stephanie.
My unmute button never seems to work when I wanted to. No, Brad, I was just keeping my eye on the time because I know that we're due to wrap up at 11, and I know that you wanted to have an opportunity to have an idea gathering session. But what I will say with respect to the community health workers is that I pushed very, very hard for that legislation to pass this session. And I really want to thank the partners who are on this call, who were also a part of that. It was a team. So I'm deeply committed to having community health workers be much more integrated into the delivery care model. So I will be talking, I've already said this to our friends at CHN around the work that they're doing, and also inviting some other partners in so that here at DSS, we can have a model that, or at least start to talk about, creating a model that we think would be effective and efficient and address many of the concerns that you've raised, especially Alice, what you talked about. And particularly, Ellen, what you mentioned about the reticence to enter into care because of the long-standing histories of discrimination and terrible treatment in the medical community, that there's no getting around that. That's what our history tells us. So that's what I wanted to say. Brad, I want to turn it back over to you because I know you want to have a listening session. I want to make sure we have time for that.
Well, I think this is honestly, we've been having a lot of listening session as part of this.
That's fine.
Categorize that this process has actually been us, and I know Olivia and team are taking notes on the comments, so we can categorize them. But I do want to make sure that Stephanie has an opportunity to weigh in because I know had her hand up for a while.
That's fine. That's all I wanted to add. Thanks.
Good morning, everyone. I'll try to keep this as brief as possible. I am wanting to echo what Alice said, what Ellen said, what Reverend Anderson said, and thinking in terms of like a partnership that I coordinate here throughout Southeastern Connecticut, right? So we have the Health Improvement Collaborative of Southeastern Connecticut, right? So it is a multi-sector, multidisciplinary partnership of individuals and organizations who really are just connected to help folks in our region live their healthiest life, however that looks for them, right? And so it brings all those points of other folks that I just mentioned. Ellen talked about like the web, right? Like that's literally how our Health Improvement Collaborative operates, right? So there are community health workers that are employed by one of our community action network, our health departments, and the hospital. All of these folks are working together for these referrals. There are peer navigators who are working with the health department and our aid service organization. So like we have this thing that works. And I actually just texted our director of health and I said, I know we do referrals for like all of our CHWs and do we use this referral service? Because I know that they've also presented to us to say like, we are sort of the way to do the referrals. We don't actually use them. And I'm not saying that like ours is like the way to go. I'm just saying that we are using the model that Alice and Ellen and Reverend Anderson, Ms. Angela talked about, where we're making these referrals to partner organizations on our collaborative. And again, it's, we have a limited amount of folks in our area who are doing the work, but it is getting done. And so hopefully as part of our ongoing conversation within the context of this group, we talk about what I believe Alice and or Ms. Ellen said about, getting resources to the primary care folks, because if we're expecting them to do more, we need to make sure that they have the resources they need to do more, right? To hire more staff, the doctors and nurses, as well as the support staff. And we need to also be making sure that our community-based organizations, public health departments, and other partners have the resources they need so that this sort of thing that we have going is happening more across the state. Like that's some sort of model like that, so that we can then make sure that the folks who have Medicaid all of their needs are being met as best as possible. Thank you.
Thank you, Stephanie. I'm going to take us to 11:15, just high level overview. We're not going to, we don't have a ton of time left. And I think, again, this conversation has been the conversation I think we were looking to have, is to get all of your input and thoughts on this. But I think it actually leads nicely just to say, talk briefly about 11:15 waivers, which we understand not everyone knows a ton about, but just to say we are exploring it at DSS, what an 11:15 waiver would do, and that of potential options include housing and nutritional supports for members. However, we need additional executive and legislative approval before we would be able to proceed, which we don't have at this time. Next slide is just kind of giving some information about 11:15s. 11:15s, basically Medicaid authority without an 11:15 is very limited in terms of what we can use Medicaid funds to address in terms of non-medical, non-traditional medical services. Under an 11:15 waiver, you can waive those rules and cover services related to health-related social needs, which other states have done. Most recently, Arizona, Arkansas, Massachusetts, Oregon, and also New Jersey was just approved. These services under these new waivers that are authorized include housing, nutrition, and health-related social needs case management. I think a lot of the things we were just somewhat discussing. The financing, there is a change in how CMS is approaching the financing, which is important to understand that they've reapproached budget neutrality, and that health-related social needs spending under an 11:15 does not need to be offset by savings. That was not the case previously. There had to be offset savings to include them. So that is a change, as well as they're allowing states to spend up to 3% of their total annual Medicaid spend on health-related social needs. So those are two new important parts that are related to this broader conversation we're having. Next slide. And so we just highlighted those states. There's several that are pending. And again, as I mentioned, we're thinking about it. I will pass it quickly to Olivia just to highlight what some of those other states are actually doing that are recently approved or had been approved previously. Olivia?
Yeah, thanks, Brad. So I'll be quick about this and say, there's a lot underneath all of these programs, but we want to give you a sort of couple of examples of programs that were approved prior to the more recent approvals and release of guidance around health-related social needs. So a couple of Vanguard programs that are worth noting. The North Carolina Healthy Opportunities Pilots Program was approved in 2018. This program was really sort of first of its kind in terms of allowing the Medicaid program to pay for non-medical services that target HRSN. So this was prior to the more recent approvals, but is sort of similar in that it actually funds service delivery. It is a pilot program, so it's much more limited in terms of its scope across the state, in terms of the region it operates in. And it's based fundamentally on a series of regional organizations called Network Leads, which really serve as the sort of conveners and coordinators of a network of CBOs that actually deliver the pilot services. The program is pretty highly integrated with North Carolina's managed care program. So MCOs are responsible for managing the budget, determining eligibility, and authorizing the delivery of services. This program's notable in that it actually defined 29 SDOH related services and priced those services. And just I'll mention, just because Mark, I know you asked the question earlier around accountability. They were looking at how to bundle payments to those network leads for delivering those services, and had previously anticipated a pathway to those entities ultimately being able to share in savings. The program was sort of delayed in implementation, so I'm not sure they're there yet in terms of those pilot and MCO partnerships, but worth noting that was anticipated under this program. And then Washington, another example, just briefly note, this one's perhaps a little bit more representative of some of the prior approvals in that it does not fund the services themselves. What it authorized was performance-based incentive payments for the regional entities that Washington had established actually under their SIM model. These are regional entities referred to as accountable communities of health that similarly serve as conveners and coordinators and really work on specific healthcare and social needs related projects and activities in a particular region. So those entities are authorized to receive performance-based incentive payments. They do not provide, they're not paid for the delivery of services, which is really, if I flip quickly to the next slide, what the more recent 1115 waiver approvals have done, which is change the landscape in terms of what CMS is willing to approve from a service delivery perspective. So it's worth noting across all 4 of the programs that were approved in fall of 22, that there's a sort of commonality in the kinds of expenditures that were authorized. The programs all focus on different target populations. I won't go through that in depth, but just to say, from a service delivery perspective, they are delivering housing supports. All of the programs are doing that. Some of them are also delivering nutrition supports. They're all delivering case management services around referring, screening and referring people to HRSN services. Massachusetts is uniquely providing transportation to HRSN under their waiver. That's something CMS has said they would authorize on a case-by-case basis. And then the other sort of important innovation here is the funding for HRSN infrastructure. So under those new financing rules that Brad mentioned, these states have all been allowed to spend up to 15% of their total HRSN spending on infrastructure to support the delivery of HRSN services. And again, different sort of focus in terms of, Arizona's program is very targeted at members who are homeless or at risk of becoming homeless. Arkansas is using a different sort of intensive care coordination model for 3 high needs populations. Massachusetts program is pretty integrated into their broader ACO program. And Oregon is specifically targeting members who are experiencing major life transitions. They all have highly defined criteria around, which members qualify for those programs and services. I realize that was very quick, intentionally so. So let me pause and see if anybody has any questions.
And feel free to bring it up. We're basically leaving the rest of time for conversation, which you've already been doing. So, Mark.
Thanks. So 2 comments. One is, it's notable that I didn't know this about North Carolina, but in the Washington Accountable Community Model and in Oregon, there's a recognition that a lot of the problems, the barriers are very local in nature, and they require both an understanding regionally of what the barriers are, even at the neighborhood level, and this network or web of entities that have relationships. They know the food pantries, they know the beauty salons, barbershops, and that sort of thing. That some of the work that I think, say, CHN Connecticut is trying to do around primary care attribution is great to try to orchestrate from a statewide level, but in some ways, the idea of regional coordination, regional hubs, regional accountability is an attractive one that I think is worth exploring, and one that I think could enable one to capitalize on the existing regional structures for driving transformative change, like what Stephanie Clark was talking about with the Health Improvement Collaborative in the Ledge Lake District, which is, there's hospital participation, many community organizations, the health district, and that sort of thing. And they're working on exactly the kind of upstream issues that Ellen and Alice were discussing, as well as also downstream access issues and that sort of thing. The second question I had was the 1115 waiver that you are exploring, Dr. Richards, seems like it's narrowly focused. And I believe in all the states you've looked at and all the states we've looked at, there's a broader more comprehensive 1115 reform structure in which they're doing a lot of different things. And HRSN coverage is just one element of a sort of a system of initiatives that are intended to achieve impact. So are you looking at another like narrow only 1115 SUD targeted type thing but for HRSN? Or are you contemplating possibly that the Advanced Primary Care Initiative and that other initiatives, including HRSN coverage or CHWs, could be subsumed under a broader strategy like what Massachusetts, Oregon, North Carolina, Vermont, Rhode Island, and others have done?
Just on, at least on the last one quickly, Mark, I'll say, I don't think we have not finalized kind of the approach, and we're definitely exploring, I think, all options that are on the table. And so those, it's not necessarily a narrow focus. So there's obviously a lot of internal buy-in and discussion that needs to occur. But definitely not saying it's narrow. Obviously, we just mentioned the housing and others because I think they're very applicable to today's conversation, acknowledging that there's opportunities within 1115 to do other work as well.
Well, I appreciate all the data you're sharing here and the look at other states. It's enormously, I think, instructive for this work. So thank you.
Thanks. I think Karen is, let me make sure I got the order right here. Karen, and actually maybe Olivia will switch to the slides where we're taking notes because we've already been, Olivia's been diligently taking notes already. And so we can just flip to that because that's really where we want to spend our time anyways, further comments, considerations, or again, where does this fit? And then also as we think about where does primary care fit within this scope, we understand both these interface, and we understand that there's different approaches to try to get these pieces to fit together, and we are interested in thinking about both of them. Karen?
I just wanted to lift up some things that others have said, including Stephanie and Angela and Mark and Ben in the chat about local solutions and the need for some coordination. And I just wanted to say one of the things that I think has been really innovative and helpful in other states, and it has been built on MCO structures but doesn't have to be, is the kind of support that CBOs need to participate in these processes and to collaborate with clinical providers. And this is something I've talked about before, but this simplifies the process for the families, for the people, for the members at the end of the process, but it also makes the programs more efficient and effective. And I think there are lessons learned from recent programming in Medicaid that could be useful in designing and implementing some kind of regional infrastructure that addresses both the needs of this primary care reform and other programs that Medicaid has undertaken, like the CHESS program and the violence prevention program and INCK, that provide the kind of HR and billing and data sharing support that smaller organizations need in order to be able to do their work well, and allow them to use other kinds of funding to supplement what Medicaid can't support without becoming so burdensome and so costly that they essentially can't do the work. So I don't want to go on forever about this. I just wanted to lift up that as being kind of central to bringing all of these pieces together, is that infrastructure.
Thanks, Karen. Ellen?
Thank you. A couple of things there in terms of learning from other states. I know there was semi-recent, evaluations that came out about the accountable communities of health in Washington, and very disappointing results. And maybe looking at that and learning from that. I'm not saying don't do this, but just not make the same mistake they made. I found that very helpful. I reach out to advocates in other states, and you can learn a lot that way. The other thing is that 3% of our revenue, the 1115 waiver, I would not suggest spending that much money on this. Half of that is going to come from the state budget and out of exactly the kind of public health, community service pieces that could potentially come from those. So I don't know that as Medicaid does only allow you to spend for a very narrow set of things, to be honest. And it's more setting up people and referrals to where they actually get help. The medical service, there's care management, and that's helpful, but the medical system doesn't deliver housing and doesn't typically deliver food. Some of those pieces are have to be funded out of the general fund. So I think while you could spend 3%, I would urge you to spend far less.
So, Alice?
Great. Echoing everybody said, I just want to say a couple things. One is that this is an opportunity to, as Ellen is saying, actually begin a community philanthropic partnership. I know Tiffany Donaldson is on from the Connecticut Health Foundation. She's been extremely helpful to Clifford Beers setting up the CMS project and filling in the gaps where CMS allows or doesn't allow. I just also want to point out that INCK is actually not using 1115A waiver. We're using targeted case management after, and Erica can testify after 2.5 years of debating which to do. The reason we're doing the targeted case management is that there are providers who can actually, we're not licensed providers. So we're training local community-based organizations who do not currently bill Medicaid to actually be able to use the CMAP and get it. The targeted case management is an alternative payment methodology. It's a tiered on needs, and money is associated to the tier. Very complicated tiering system, but I think that allowing groups like Project Access, Christian Community Action Agency, and Urban Trauma Association and other groups, training them in wraparound care coordination and allowing them to access other dollars, Medicaid dollars, to be able to deliver the really holistic kind of care that they do through multiple grant funding is really has been kind of hopefully revolutionary for the payment structure. But I really want to give a shout out to Connecticut Health Foundation and their support of this kind of innovative work. So thank you.
Thanks, and Tiffany?
Thank you, Alice. But really, it's about the partners who are doing the work. There's always opportunities for public-private partnerships, and this could be a time that we need to continue to leverage that. I know this was a listening session, so I've been listening and trying to figure out when to provide my input. This has been a phenomenal conversation. But as we're considering these models, I think folks are elevating some critical points that can't be lost. As we are thinking about primary care reform in general, and as we're thinking about improving the well-being and really the health outcomes and the social outcomes of Medicaid patients, we have to be honest about what primary care has the capacity to do, who our patients trust, and who they will be most effective in providing the connections and the outcomes. And then we need to consider how the financing needs to support that system. So we talk about supporting the infrastructure for the community-based organizations. We also need to consider, as we are doing payment reform, how are these community-based organizations also going to be a part of the funding and the shared savings as we are thinking about these models. And that's critically important as we move forward, because again, we need to be honest about who is most capable of doing the work and who can do the work. And again, also those connections to primary care, assuring that people have connections to medical care in the most appropriate way, but they also have connections to the social needs that they have. How do we do that in an effective way where we aren't creating silos? So that is really where I am concerned, is about siloing our financing and siloing the processes. And so as I'm providing feedback, my feedback is how can we do this most effectively, where we are really thinking about the whole person and what they need, and building a financing model, a model that works for the whole person.
Thanks, Tiffany. We're just about at time, and I wanted to first see if the commissioner wanted to have any last words, and I can give a quick overview of process steps next. But Commissioner?
Thank you, Brad. I truly appreciate everyone's input today. I hope that you found this meeting to be productive. You can see we've been furiously taking notes. I have been as well on every device I have, my cell phone, the laptop, everything, so that we can capture all that you have. And I hope that our future meetings will be just as productive. I can tell you when we get into September, and Brad will talk about that, what we plan on doing as we move forward, so capturing where we are, laying out a roadmap, determining where we need to go, having some timeframes around that, so that we can know that we're all contributing, but also making progress. So thank you very much for everything today.
Yeah, thank you, Commissioner, for that. And just echoing, thanks for the participation. And again, hopefully this is really getting to some of the meat of the conversation that we were all looking for. So looking to next steps, we'll review these notes, make sure that they're tagged. We'll obviously send this out. We'll send out a post-meeting poll, as well as look to schedule a supplementary data meeting to discuss the data that was sent out. And we'll be working on the plan for August. So we're at 11. Again, thank all of you again. We really appreciate it and need you to participate in this and look forward to the